So as a teenager, I had been aware of the investigative work done by CDC during the 1976 Legionnaire's disease outbreak in Philadelphia. But it was during my medical residency that I really began to understand public health. I saw that in the response to infections in our hospitals, to rising cases of measles, and the investigation of mad cow disease. And while I very much enjoyed working with one patient at a time, public health offered the chance to improve the health of entire populations. And I wanted to give that a try too. So after residency, I joined CDC's Epidemic Intelligence Service, or EIS, sometimes known as the Disease Detectives. I found myself in Pakistan evaluating the validity of survey questions on immunization rates, and later on rooftops in Los Angeles, sampling water from cooling towers for the now well-known Legionella bacteria. After EIS, I returned to clinical medicine to complete my infectious disease specialty training and was immersed in the rapidly evolving world of HIV treatment. A few years later, I moved with my family to Kisumu in western Kenya. My husband would be directing CDC's research field station there. I was the trailing spouse, having spent the previous few years continuing to provide some HIV care, but also focused on our very young children. In Kenya, I was initially planning to do malaria research, but it was immediately apparent that it would make much more sense for me to apply my experience with HIV. And when we arrived in 2001, 1 in 4 adults in Kisumu had HIV. Coffin makers were thriving. Almost all hospitalized adults were HIV positive. And CDC's research programs had to hire 125% of needed field staff because so many people were dying on the job. Against that devastating backdrop, the world was starting to realize that HIV services needed to be offered in some of the hardest hit parts of the world. The initial focus of these services was on testing and on prevention through counseling and by providing limited treatment to pregnant women to keep babies from acquiring HIV. The counselors at the testing sites were very frustrated. If someone tested negative, they could share advice about how to stay negative. But for the many people that tested positive, there was very little to offer. So I had access to very limited resources at that point, but there was clear evidence that an inexpensive antibiotic, trimethoprim sulfamethoxazole, you might have heard of it as Bactrim or Septrin, or you might know it as TMP sulfa, could help protect people from many of the infections that developed in people with HIV because of their weakened immunity. So we established some clinics and provided that antibiotic. It didn't control the HIV, but it did dramatically improve our patients' health while we looked for a way to access definitive treatment, the antiretroviral drugs, or ARVs. I'd heard of a grant opportunity from Columbia University's School of Public Health, and 3 friends and colleagues, one working on prevention of mother-to-child transmission, one supporting a community program, and one from the provincial hospital, and I put together an application. That grant provided drugs for a very slim subset of our patients, women who were diagnosed during pregnancy. And we got a few individual donors and church groups to help us with drugs for a few more of our patients. It was very slow progress, but it helped prepare us for what was coming, the resources that would be coming, and they did come. So in 2002, the Global Fund for AIDS, TB, and malaria was established. And in 2003, President Bush announced that the U.S. would support HIV treatment through his signature program, the President's Emergency Plan for AIDS Relief, or PEPFAR. Knowing that the treatment drugs were on the way, we continued to expand. My Ministry of Health colleagues and I went to scores of hospitals and health centers offering to help establish HIV treatment clinics. And usually the healthcare staff would say they wanted a clinic, but they didn't have the resources or expertise. What a privilege for me to be able to say we can offer both. My colleague at USAID and I found an organization that could procure drugs, the Mission for Essential Drugs and Supplies. We just had to move the money. The contracting office put us in a bind. At first, they moved very slowly. Then suddenly they gave us an ultimatum. They would finalize the contract, but only if we could secure signatures from 6 board members scattered all over Kenya over a weekend. So my colleague John took Eastern Kenya, and I took the West. With the CDC driver, off we went. I had the easier job because all the board members were bishops, but 2 of mine were Anglican, meaning they had wives. Made them easier to find, and the wives helped us track down their husbands. So cell phone coverage was limited, and we chased several false leads down Kenya's rough roads. But by the end of the weekend, John and I had both secured our share of the needed signatures. To people who'd been asking, when are the drugs coming, I could soon say, they are here. I had lived through the transformation of HIV in the US, from a death sentence to a manageable chronic illness, and now I had the privilege of witnessing that transformation again on a massive scale. By the time my family returned to the US in 2005, 65,000 people in Kenya were on treatment, and that's a tiny fraction of the number who have since initiated care. But that early period was transformative. The coffin makers returned to building furniture, ambulances stopped serving as full-time hearses, and weekends, once dominated by funerals, were once again times for dance parties and weddings. The effects of establishing HIV programs began to ripple outward, strengthening the health system. Trusted relationships with our Ministry of Health colleagues deepened, and that trust meant we were often the first called when new threats emerged, whether it was anthrax or a hemorrhagic fever, and we were able to assist with controlling those threats, protecting both Kenyans and people in the US. Taxi drivers in Kenya are a great source of wisdom. During my frequent trips to Nairobi, I often asked for their perspectives, and every one of them had been touched by HIV through a sibling, a spouse, or their own diagnosis. Many had faced initial reluctance to get tested or seek treatment, but in overcoming stigma and barriers, they found a return to normalcy and a deep gratitude to the Global Fund, the World Health Organization, and the United States. So maybe not an aha moment, but a quiet recognition that focused programs can build immense goodwill, and I had the great privilege of being a small part of that.